Thank you, Paul. So, a word about me. As you've heard, I'm lucky enough to head up an amazing team of data engineers and data scientists at Providence St. Joseph Health. Providence is a 51 hospital healthcare system in Western United States with 9 or 10,000 employed physicians. This story began for me and my team right here. This is a photo of Jay Inslee, governor of Washington, on January 21st, 2020. He was announcing that the first known case of COVID-19 in the US was admitted to one of our system's hospitals. This screenshot, interestingly, could be used for one of those "can you spot the errors" games in retrospect. You can see the New York Times was referring to it as the Wuhan coronavirus. You can see that at the time, public health authorities thought that we could successfully keep it out of the country by expanding screenings at major airports. You can see nobody here is wearing a mask. In fact, at the time, public health experts were recommending against members of the public getting masks. So my point here is not to point fingers. It's just a perfect beginning for this story, which is all about learning as we go. So let's fast forward to March 1st, 2020. Before March, COVID was more of a curiosity for us than a real going concern. But by the beginning of March, we just started to admit in our healthcare system more than just that first patient with COVID. So this graph shows our COVID-19 hospital census, so how many people were admitted to the hospital in beds at a midnight with COVID at the beginning of March. So you can see that the numbers are small at this moment, but here's how this talk is going to work. I'm going to keep showing you this graph, our COVID hospital census, moving in 15 to 30-day increments. And at each increment, I'm going to ask this question: what were we thinking? So, what were we thinking from an analytics point of view on March 1st? On March 1st, the name of the game was detection. We had very little testing availability, and we were suddenly quite concerned that there was coronavirus circulating in our communities that we weren't aware of. And so the very first thing I did was actually picked up a pencil and I drafted onto a piece of paper this little note, imagining what we could build in the form of a dashboard that might be useful for helping us detect coronavirus in our community. So there's a lot going on here, but the basic idea was, can we render a map, which I've shown crudely on the left-hand side of this paper, that shows by zip code the percentage of patients who live in that zip code who present with a syndrome that a user can select on the right-hand side of the screen, like cough and shortness of breath. So in order to make this happen, we felt that we needed to extract relevant clinical information, so relevant clinical features like fever, cough, and shortness of breath from each one of the hundreds of thousands of clinical notes that we wrote each day. So here was our incredibly early version of natural language processing. It was not even natural language processing. It was simple text parsing. We wrote SQL that pointed against hundreds of thousands of notes every day and looked for particular phrases. For example, we were interested in the time in travel to China. The problem with looking for China is you're going to pick up echinacea, adopted a 2-year-old girl from China. She injured her hand on broken china, or you're going to get negations like no travel to China, or you're going to get the conditional statements that particularly bedevil healthcare writing, like consider precautions if traveling to China. And so we moved from that very quickly onto a slightly more mature version of natural language processing. We used Spacey for sentence segmentation and part of speech tagging. And we used clinical expertise to generate all the different ways that a group of us clinicians could think of that we could express fever, cough, runny nose, and so on. And we used Spacey to look for those in clinical notes. We also used a negation tool called NegX, which is compatible with Spacey for basic negation detection. This worked a lot better, but it was still far from perfect. Here are some real-life examples of things that were present, clinical entities that were present, but were labeled incorrectly as not being present by our NLP tool. For example, in this first sentence, the patient had a fever of 102, but because the word "not" appeared way earlier in the sentence, the patient was labeled as no fever. In the next example, you can see that the patient was without shortness of breath plus cough, the system did not understand that oftentimes in medical writing, plus means to indicate the presence of an entity. And so it applied the without to the cough and indicated no cough. And the third example, even more complicated for our poor, simple NLP engine, plus non-productive cough. So this patient definitely had a cough, but they were labeled as not having had a cough. Let me just fast forward to the present. What we're actually doing is using an open source tool called Prodigy and having clinicians on my team do detailed annotation for sentiment like negation around entities of interest. So in this particular case, I would have looked at this note and said, okay, fatigue and fever are the entities being described here. Both of them are being negated by this word negative for, and I would have actually drawn an arrow between negative and fatigue and negative and fever. And then we can use, after doing many thousands of such annotations, we can train a machine learning tool to detect negations in situations that it hasn't seen before. Early on in the process, this was right at the beginning of March, we realized we needed a data architecture to support what we were doing. At the time, we were really thinking about detection and thinking about syndromic surveillance, and we decided to create a registry. So one row for every single patient encounter inside our 2 electronic medical record systems, with columns for basic stuff that we thought we would need, like demographics and basic clinical features, variables, based on, so indicator variables based on things like, did the patient in the NLP have shortness of breath, fever, cough, etc. And as time has gone on, as you might imagine, this kind of one simple table has grown into sort of a whole network of staging tables that feed into this table, along with many hundreds of columns, including features like how sick was a patient at the time of presentation, like what was their SOFA score, what was the patient's D-dimers when they showed up in the ED, how many doses of remdesivir did a patient receive? Did they get intubated, etc. In a big organization like mine, if you're a clinical analytics group, you will find that branding is important for getting your voice heard. And so early on, we decided to brand all the stuff that we were producing around coronavirus under the name COVERED, which stands for Coronavirus Epidemic Registry and Emergency Data Platform. We've subsequently produced many different dashboards, each one of which has a header that looks very much like the one that I'm showing on the screen. Every dashboard has these 4 blue circles on the top right of the screen, and users know that they can click these circles to get at things like data dictionary information, to log bugs, to ask questions. We make sure to use the same type of filters across all of our different dashboards as well, whenever possible, and we use the same color scheme. So light blue across all of our dashboards means non-COVID patients. This orangey color means patients under investigation, and this kind of rust color means patients with COVID. Another thing that became obviously important within the first few weeks of March was the need for governance. So we have a variety of different analytics groups around the organization, and each one was being asked to produce overlapping things related to COVID by different senior executives in the organization. And so we pulled together this governance group, and we started by meeting every day of the week to talk about what are we being asked to do and to figure out how to coordinate work and assign work across teams. We're now down to meeting about twice a week. So the very first visualization, or one of the very first visualizations that we produced then, was the kind of realization of my little scroll on that piece of paper. So here what you're looking at is a jigsaw puzzle that is the zip codes that we cover in Washington State and Northern Oregon. Each piece of the puzzle then is a zip code, and the color coding indicates the percentage of patients who live in that zip code who have seen us during a period of time that the user has selected, who also have clinical features that the user has selected from the filters on the right-hand side of the screen. So in this example, I'm looking for patients who have fever and cough and shortness of breath and do not have a diagnosis of influenza. The brighter the orange, the higher percentage of people from that particular zip code have the syndrome of interest. We built something very similar that was designed to work at the level of the site of care. So each of these circles represents one site where we provide care, and the ones in orange represent sites of care where we're seeing, when we compare a period 1 with a period 2, a statistically significant increase in the syndrome of interest in period 2. So for example, again here I'm looking for fever, cough, shortness of breath, and no influenza. I'm looking at family medicine practice in California. You can see that during time period 2, we saw about 7,400 patients, 36 of whom satisfied the syndromic criteria that I've specified on the right of the screen. And during time period 1, which happens to have been the same 2-week period the previous year, we saw about 6,000 patients, 10 of whom satisfied the syndromic criteria. That difference is strongly statistically significant, which is why it's colored in orange. And this little calculator tells us that we've seen 20 excess patients satisfying these criteria during period 2. So all of that was built with a very intense interest on asking the question, can we detect coronavirus in the absence of good testing inside our communities? Here's where we were on March 15th. That we had gone from coronavirus being something pretty theoretical to something that was really a going concern. We had a census of 61 across our system, and like many organizations, we suddenly realized that we were woefully lacking in people with experience doing agent-based modeling. So what everybody wanted to know at this point was, what's gonna happen next? We'd moved away from an emphasis on detection towards a strong emphasis on, can we predict how bad this is gonna get? So what I'm showing here is an actual slide that I shared with our organization's executive council on March 18th. I must admit, I am not an agent-based modeler. I did my best. I showed my assumptions at the top left of the screen, and which, under the expectation of exponential growth, yielded the COVID census forecast shown on the right-hand side of the screen for one of our hospitals. This is actually, incidentally, the hospital which cared for the first known COVID patient in the US. The really relevant curve here is this orange curve, which shows our projected census in the intensive care unit, which maxed out in early May, according to this forecast, at 181 beds. And this was alarming because this particular hospital only had 50 beds to care for anybody. So we didn't know what we were going to do if we had 181 patients. I must say that when I saw this, I thought, I can't believe these numbers. And so I reached out to more experienced colleagues of mine at a number of academic medical centers. They were kind enough at the time to share their modeling systems with me. At the time, there was very little online. Now there are a whole variety of very nice calculators for making these kinds of projections. They didn't exist in the middle of March. So a number of academic medical centers shared their models with me. I plugged our numbers in. One of them yielded a peak of 268 patients requiring ICU beds at that one hospital, but again, had a capacity of 50. Another model predicted 250 beds. The Imperial College of London paper that got a lot of attention using their assumptions, I got 255. And the one minority report, so the lone dissenter, was the Seattle-based Institute for Disease Modeling, which predicted 35 beds would be required. In real life, we needed 15 beds, and we peaked not in May or June, as many of our models had predicted, but we peaked on March 24th of 2020. So we learned a lot in this process of making these predictions, and I'm going to talk a little bit about our learnings in a couple minutes. But by the time March had turned into April, what we were really concerned with was not, is this going to be a big deal? It already was a big deal, and we were very concerned about operations. So, for example, we were quite interested in understanding in as close to real time as possible what's happening on the floors of our hospitals and how close are we coming to hitting capacity. So one of the dashboards that we built uses near real-time data that's updated hourly from our 2 electronic medical record systems. And what you can see at the top left of the screen is this donut showing how many patients in total are currently censused at our hospitals, how does that relate to our total capacity, and how many of those are COVID patients. And as you move your eyes over to the right-hand side of the screen on the top, you can see that broken down into ICU, non-ICU patients with these little kind of battery-like things at the bottom of these tiles, which give you a sense of where we're at relative to capacity. The user could also click on one individual hospital and see on the bottom right-hand side of the screen where patients are situated. Another thing that was of great interest was the same data, but trended over time. This particular dashboard is by far the most trafficked dashboard that I have ever been involved in creating in my career. We've had more than 60,000 views over the last several months. So it's very actively used. Laboratory testing became another great concern. We developed this dashboard also out of the same registry data structure that shows day by day how many tests we've done and the results of those tests. Again, we're maintaining the same color symbology across all of our dashboards. On the bottom of the screen, you can see the percentage of tests that have been positive over time. And just zooming out a little bit, here I'm looking back to the beginning of March. And one of the things that I find remarkable about this is just how many tests we've been able to do. At the time that I took this screenshot, we had managed to be more than 1,000 COVID tests on our patients, and the amount of growth in our testing capacity over time, which I feel like is a great testament to the incredibly hard work that's happening on the ground. So by the beginning of May, things felt a little bit more under control. We had the staff, we had the space, we had the personal protective equipment, and the numbers were not increasing dramatically. And so at that point, the questions that flooded into my team, especially related to how do we learn from the experience that we've had? So one area of learning had to do with what kind of outcomes are our patients experiencing, and can we figure out how to optimize them? And so, for example, in this dashboard, what you're seeing across the top of the screen is key statistics that users were able to select for an individual hospital, a region, the system, such as the percentage of patients that were admitted to the ICU, the percentage of COVID patients who needed a ventilator, the percentage of patients who died, and detailed data related to length of stay. Users are able to filter this dashboard according to a variety of different parameters that are available on the screen. One of the things that using this data structure we observed was really fascinating to me, which is how the way we're managing patients has changed over time. Here are just a few examples. In the top of the screen, you can see the running sum of all the COVID patients that we've admitted over time. On the bottom of the screen, you can see some changes. For example, in blue, you're seeing the change in the percentage of patients who needed ICU care. We went from 30 or 40% down to, by the end of June, we were more like 20%. Percentage of patients who needed mechanical ventilation went from 20 or 30% to under 10%. And the percentage of patients who died under our care went from 21% early in the pandemic down to 13%. And there have been some big changes that we've been able to detect in the way we're caring for patients. We're holding off on ventilating using high flow nasal cannula. We've almost entirely stopped using hydroxychloroquine. We've replaced that with remdesivir. We're using dexamethasone in many of our patients. We're using proning more than we were at the beginning. And so it's really fascinating to see how we've been able to learn from the experiences of our clinicians. Another type of learning is building predictive models that can assist clinicians at the bedside. So here's a typical decision. I'm an ICU, imagine I'm a physician in the emergency department. I see lots of patients who have potential COVID, and I've got to decide which of those patients probably need to go to the hospital and which are safe to send home. We know that about 10% of patients experience bad outcomes, like they die or they need intensive care. So how am I supposed to know as an ED physician, which of those patients are safe to send home and which are destined for a bad outcome? And so we've developed a predictive model using the data that are available in structured fields early on in a patient's arrival in the emergency department to generate a model that does something like this. So here are 200 imaginary patients. The ones in red are the ones who are destined for a bad outcome. There are 20 out of the 200 on this slide. Our model is able to divide the population into two populations, high risk and low risk. In every high risk 100 patients, 19 of them are destined for a bad outcome. In every low risk 100 patients, only one of them is destined for a bad outcome. and actually looking retrospectively to see whether or not how many of these patients ended up getting admitted. In the high-risk population, 29 got admitted to the hospital, which kind of makes sense. 19 of them we know are at very high risk. In the low-risk population, 24 of them, in the absence of this model being available for physicians, ended up getting admitted to the hospital, suggesting that there's probably a value in this model for our physicians. On June 1st, things had changed a lot. May 25th saw the killing of George Floyd, sparking large gatherings that promoted racial justice around the country. And this heightened consciousness led to urgency around understanding whether we were seeing racial disparities in our healthcare system. And so the emphasis on learning substantially increased at the beginning of the month of June. Here is one of the analyses that my team did related to racial disparities. What you're looking at here is the age distribution of white patients presenting to our emergency department with COVID. What you can see is that there's a preponderance of presentation among older white individuals, no surprise. Here's the same distribution, but for Hispanic patients. That's a dramatic difference. The modal age at presentation is 85 and up for white patients and 45 to 49 for Hispanic patients. So the question here was, is this all demographics? In other words, we're seeing a lot of middle-aged Hispanic patients with COVID in our EDs. Is this just because there are a lot of middle-aged Hispanic individuals in the communities we serve, or is something else afoot? So we were able to collect demographic data on the populations of patients that we care for. So this distribution of age represents the distribution of age in the communities that we serve among white individuals. So these aren't our patients, these are just people living in the community. So for example, around 8% of white individuals living in our communities are aged 25 to 29. About 2% are aged 80 to 84. Going back to this slide, showing people who are presenting to our EDs with COVID, as you can see, older people are highly overrepresented in our EDs relative to their representation in our community. Check out age 50 to 54 specifically. This age is what I call the break-even point. So about 7% of white individuals living in our communities are aged 50 to 54, and about 7% of white COVID patients in our EDs are 50 to 54. So white people in that age group are proportionately represented in our EDs. Let's take a look at the Hispanic population in our catchments. So much, much younger than our white population. But take a look at this. Again, in the background in yellow represents the distribution of Hispanic patients presenting to our EDs with COVID. Those aged 50 to 54. Look at this. People aged 50 to 54 account for less than 4% of the Hispanic population in our communities, and yet approaching 12% of all the Hispanic patients that we see with COVID in our emergency departments. This overrepresentation relative to their fraction of the population is dramatic in the Hispanic population from aged 40 to age 60, and we're not seeing that in the white population. And what I'm showing here for patients arriving in our EDs is also true for patients who are sick enough to need admission to our hospital. So what's going on here? I don't pretend to know, but I do think that the most convincing explanations have to do with differences in exposures, maybe related to occupation or living conditions. What's clear is that this is not an isolated analysis. So separately, we found that Hispanic individuals living in our communities are significantly more likely to get COVID, to die of it, and even to be sent home from our emergency departments after presenting with COVID. So it's very clear that we've got a lot to figure out related to healthcare delivery. So just when we thought it was safe to go back in the water, literally in July, we got this big spike of cases, especially in Orange County. And on July 1st, then, we were really thinking again about the question of prediction. So we'd learned from our past mistakes that trying to make predictions months in advance was a fool's errand. And so we asked ourselves instead, what data sources have we got that can help us make predictions 2 weeks into the future? So let's go back and look at this tool that we built in March. Remember that orange means that it looks like there's COVID activity, COVID-like illness. Here's the period in March of 2020. And for every time I advance the slide, I'm moving forward by a 1-week period. And so you can see that early in March, we were having lots of COVID activity, March and April, lots of COVID activity in LA County, which is just northwest of Orange County, and things quieted down. And then come May, this happened. And by the end of June, we were seeing very substantial activity in Orange County. What was really fascinating about this is that we weren't starting to see a lot of cases in our emergency department until this point. And so the question is, could we have a few weeks earlier used this data to predict what was going to happen in our hospitals? Let me show this another way using one of our other regions, Eastern Washington, Montana. The top graph is going to show the percentage of outpatients who have fever, cough, and shortness of breath, so syndromic surveillance. The bottom graph is going to show hospital census in that region. And watch how the upper graph presages what happens in the lower graph. And so what this inspired us to do was to create what we call a surge detection dashboard that places leading indicators at the top of the screen, leading indicators like syndromic information, percentage of patients with fever, cough, and shortness of breath, and the percentage of patients with diagnostic test positive. And in the bottom of the screen, we use lagging indicators. So we have data from the county, and we have data that shows the thing that we're most interested in within our hospitals, which is what's happening to our hospital census. Blue is outside of the ICU, orange is inside the ICU. We also have teamed up with an amazing now data modeling group that's actually able to use our syndromic surveillance data, plus our COVID test data, plus Google Health Trends data and our bed census data to make projections 14 days into the future of bed census in each of our major metro areas. So the data that I'm showing here are for Portland. Black is our actuals, and orange are the predicted census over the next couple weeks based on the information that I was describing. So always important to look forward and see how well your, or look backward, I should say, and see how well your forecast performed. And so this is what it predicted, and this is what actually happened in black. Sometimes these predictions work really, really well. This prediction made at the beginning of June about what was going to happen over the next couple weeks did a pretty good job. Sometimes our predictions are lousy. But for the most part, they have been reasonable, and they've actually been a very helpful guide for us. So here we are, August 13th. And what's really fascinating for me is that we've come to a place of balance in that we feel like there's an urgent need to do everything. We've got to figure out how to detect COVID in our community to help with decisions around opening schools. We need to figure out how to make predictions around, for example, which patients are going to benefit most from remdesivir. We need to operationally figure out how to simultaneously care for COVID and non-COVID patients. And there's a ton of clinical stuff that we still need to learn. For example, how do the symptoms of COVID manifest over time? So here's a glimpse into the future. We've started to use much more sophisticated natural language processing and mapping tools to generate a really granular and near real-time look at COVID in our communities. This is just a teaser trailer, but this project is called Detection Map, and we're hoping to go live with it to the general public in October. And we're now inviting patients who have tested positive for COVID in our system to participate as citizen scientists in a research project called My COVID Diary. So in this project, volunteers with COVID journal about their symptoms over the course of a year to help us understand the natural history of these symptoms. So to sum up, we've learned a lot, sometimes from our own mistakes, but I think the journey's just started. I firmly believe that 2 years from now, we're going to look back at where we are today and marvel at just how ignorant we are.